I'm Kareem. I'm a third-year psychiatry resident at UAB, and I did a fellowship in consultation-led in psychiatry before I start my residency. It's a long story, though we don't have time for that. However, what I'm trying to go through today is how we try to use the sublingual asenapine to manage agitation in patients who had malabsorptive states. And just a brief introduction, we know that this problem is quite common in hospitalized patients, and they do have problems on absorbing oral medications in general. And it's become more complex if their agitation or psychosis has been interfering with their care. So that's why for the cases that we will go through, we thought about asenapine. So asenapine is a second-generation antipsychotic with a good efficacy on the dopamine receptors. And it has a sublingual form which can bypass the gut absorption and can do that pretty quickly within 15 minutes if you want to control acute agitation. One important thing that I want to make sure that I explain or differentiate. So we have the oral disintegrated tablets and we have the sublingual form. So we have two antipsychotics or other psychotropics who are ODT form or oral disintegrated tablets. So basically, for those tablets, the patient, when they put them in their mouth, they dissolve and you need to swallow the tablets. For the sublingual one, you just need to put the pill under your tongue and you should not swallow it. So that's why the ODTs, although they dissolve, but again, they need to go through some sort of also gut absorption. So yeah, we have 3 patients, one with short bowel syndrome, one with viral gastroenteritis, and one with aortic dissection, who ended up with having gastric malabsorption. All right, let's go through our cases, okay? So Mr. A is a 32 years old African-American male who has medical history of heart failure with reduced ejection fraction. He also have long history of substance use disorder, mainly cannabis and methamphetamine. And he has been tried on different antipsychotics in the past. Unfortunately, he was not compliant. And we even tried him on long-acting injections. The reason he came to the medical unit, he had 1 month history of watery diarrhea and weight loss, and 1 week history of abdominal pain and abdominal distension. And the reason for his gastric malabsorption prior to his presentation, he had a history of short bowel syndrome because he developed at one point of his life necrotizing enterocolitis and ended up having a bowel resection. So the patient in the unit was pretty agitated. So we tried him on olanzapine when we were consulted, 5 milligram, 3 times a day ODT form with IM injections. It did not work. So we switched that to risperidone ODT and we went up to 8 milligram. And because of his clinical condition, he did not respond. So we decided to switch him to sublingual asenapine, 5 milligram twice daily. And amazingly, he responded within 1 day. And he received all the like electrolyte requirement because he was malnourished during his stay, and went to the psychiatry unit. Unfortunately, for some reason, he started to swallow the asenapine and his symptoms went back. So what the psychiatry team did in the inpatient psychiatric unit to request an order to treat, and they switched him to fluphenazine, 10 milligram twice daily orally. And because we have the order to treat from court, whenever he refused the oral medication, we can give him an IM injection if he refused that. So he was stabilized on the fluphenazine and we discharged him and we switched that to long-acting injection. So that's Mr. A, and he has been stable after that. Regarding Miss B, she's a 49-year-old Caucasian female with a history of bipolar disorder, and she also has a history of chronic osteomyelitis in both feet. And prior to presenting to the emergency department, she was partially treated for C. diff, and she eloped from the hospital prior coming back to our emergency department. And she was quite psychotic and manic when she presented. So we admitted her and resumed her on olanzapine and lithium at the time. Unfortunately, she was agitated and manic, so we had to add chloropromazine to her regimen. During her stay, she developed viral gastroenteritis and she started to vomit. And even we had to repeat the lithium level. So it was around 0.68, which is normal. And 5 days after she started to vomit, we found that she had low lithium level, which was around 0.38. So we decided at the time to introduce asenapine, and we went up to total of 15 milligram. And amazingly, she responding very well. She became calm, and within 3 days, she went back to her baseline. And she did well after that, and eventually she was discharged from the hospital. However, she stayed like for almost a year in the hospital because of psychosocial issues, but eventually we were able to manage her agitation, and the medical team was able to address other issues. So Mr. C is a 33 years old African-American male with no psychiatric history at all. I think he was playing a video game. He had a severe chest pain and back pain, and he was diagnosed eventually when he came to the hospital with type A aortic dissection. And unfortunately, he had end organ failure, and they had to amputate his both lower limbs. And it seemed that he became delirious during his stay in the hospital due to electrolyte imbalance. So what we did as a psychiatric team, we tried to intervene, and it seems due to the low blood supply that he has to even to his GI system, absorption of medication has been an issue. So that's why we decided to start him on sublingual asenapine, 5 milligram twice daily. And then within 3 to 5 days, he became less agitated, and he became more cooperative with the primary team. So what I'm trying to say here is that all the patients that we saw that respond significantly to the sublingual asenapine, and which stood out in the cases of gut absorption, and the response was quite rapid in reduction of agitation. Of course, one thing that we noticed for patient A and patient B, that sometimes those patients swallowed the medication instead of putting it sublingually. So that's why it became difficult to control the symptoms. And we ended up switching them back to another medication. And of course, when we swallow the medicine, I'm talking about the sublingual asenapine, this will reduce the bioavailability. Again, we don't have any clear guidelines to assist clinicians in choosing the most appropriate medication for patients with agitation and delirium with gut absorption. And we need to review alternative agents for agitation management for psychiatric care, especially in acquired and congenital gut malformation. And again, I'm just emphasizing on the role of the consult liaison clinicians on helping managing those medically complex patients. And that is my presentation, and I'm hoping for more questions.